Assalamu alaikum. Let's discuss about Marfan versus homocystinuria. In Marfan syndrome, Marfan is autosomal dominant, and in Marfan syndrome, there is lens dislocation, outward and upward. In Marfan syndrome, there is outward and upward lens dislocation, and in Marfan syndrome, there is aortic root dilatation. And a very high yield thing in Marfan syndrome, that is normal intellect. So in Marfan syndrome, these are the unique feature for Marfan syndrome, that is lens dislocation. In Marfan syndrome, in homocystinuria, both has lens dislocation. We can differentiate by these days lens dislocation. Marfan syndrome, there is outward and upward dislocation, outward and upward lens dislocation, and in homocystinuria it is downward and inward lens dislocation. We know that Marfan is an autosomal dominant disease, and Marfan causing fibrillin gene problem, autosomal uh, dominant and mutation in the gene that encodes fibrillin. And we know that fibrillin is a major component of microfibrils that supports elastic fibers and maintain the connective tissue integrity. Okay, so if we like to differentiate between Marfan's and Ehler's danlos, sorry, Marfan's and homocystinuria. In homocystinuria, it is autosomal recessive. In here, there is intellectual disability, very high. In homocystinuria, there is intellectual disability, there is thrombosis, there is downward lens dislocation, and there is megaloblastic anemia and fair complexion. So a fair complexion person with a developmental delay and uh, and a cerebrovascular accident looks like pathognomonic for homocystinuria. In homocystinuria, the overlapping features are this pectus deformity, the tall stature, increased arm is to height ratio, increased arm is to height ratio, decrease upper to lower segment ratio, decrease upper to lower segment ratio. There is arachnoidodactyly, there is joint hyperlaxity, there is arachnoidodactyly, there is joint hyperlaxity, and there is scoliosis. There is scoliosis. If we look at this stem, which I have done wrong, this 5-year-old girl, sudden onset weakness on her left side or slur speech. Sudden onset weakness on her left side and slur speech. This is a feature of thrombosis. She was sitting on the floor at home playing with her toys when she lost her balance and toppled over. Her father caught. Okay, there is a history of developmental delay. There is eye problem, developmental delay, eye problem. Okay, his fair skin, fair skin, blue eye. So fair skin, blue eye. She has a long, thin arm and a legs and decrease upper to lower segment ratio, decrease upper to lower segment ratio. Left upper and a lower deep tendon reflex are brisks. Babinski sign is upgoing on the left side, joint hyperlaxity, Skin hyperelasticity are also seen. Which of the following is the most likely diagnosis? So fair skin, fair blue skin, there is developmental delay, there is a feature of thrombosis, looks like homocystinuria. So homocystinuria, in homocystinuria, patient may have Marfanoid body habitus, they may be tall stature. This is Marfanoid habitus, increase arm to height ratio, increase arm to height ratio. There may be lens dislocation, pectus deformity, pectus excavatum, decrease upper to lower body segment ratio, flat feet. However, several features are only for homocystinuria. That fair skin, developmental delay, cerebrovascular accident are virtually pathognomonic for homocystinuria. These patients may have thromboembolic events at any age due to pathologic change in the vessel walls and increased adhesiveness of the platelets. Such events most commonly involve the cerebral vessels. The diagnosis of the homocystinuria is made based on elevated homocysteine level and methionine level. Treatment is vitamin B6 folate, vitamin B12 to lower homocysteine level, vitamin B6 folate, vitamin B12 to lower homocysteine level. In addition, antiplatelet anticoagulation should be administered to prevent stroke, coronary heart disease, venous thromboembolic disease. Ehlers-Danlos looks like this. Marfan has fibrillin problem and Ehlers-Danlos is collagen problem. It's a collagen disorder. There is joint laxity, scoliosis, skin hyperelasticity is present. In here, there is also lens, but the but patients with these disorder do not have tall stature, lens dislocation, and hypercoagulability. These three things, tall stature, lens dislocation, and hypercoagulability, is not seen in Ehlers-Danlos. It is seen specifically on homocystinuria. Okay, and if we like to differentiate between Ehlers-Danlos and the Marfan, if we look at the skin of the Ehlers-Danlos syndrome patient, there is transparent and hyperextensible. It is transparent and hyperextensible. There is easy bruising, poor healing. There is easy bruising, poor healing. There is velvety with atrophy and scarring. In in Marfan, there is no such skin feature other than the stria. So Marfan only stria, but in Ehlers-Danlos there are other easy bruising, poor healing, velvety with atrophy, scarring. In Marfan and Ehlers-Danlos, there is both has joint hypermobility, both can cause pectus excavatum. Marfan is along with causing carinatum, both can cause scoliosis. In Ehlers-Danlos, there is high arched palate, but in Marfan there is tall with long extremities. Ehlers-Danlos, there is mitral valve prolapse, and Marfan can cause aortic root dilatation, aortic regurgitation, mitral valve prolapse, and other, like in classic Ehlers-Danlos, there is abdominal or inguinal hernia, there may be uterine prolapse, but in Marfan there is lens and retinal detachment, there is spontaneous pneumothorax. Lens is dislocated outward and upward like superiorly. Marfan is FBN1 mutation, it is autosomal dominant, and Ehlers-Danlos is COL5A1 or COL5A2 mutation, it is also autosomal dominant. So the skin finding and the lens finding present only in the Marfans. These are the features we can differentiate between Marfan versus Ehler danlos. This is a very high-yield discussion between Marfans versus Homocystinuria versus classic Ehler danlos. Hope you enjoy.